multinational drug companies have taken over. And once they started sponsoring, we are dancing through their tunes. I am happy that no sponsor is
antibody for hepatitis A, right? So hepatitis B vaccination. We don't need it because he has surface antibody positive. So he's already had a protective antibody for hepatitis B, so we don't need to give vaccination. Serial monitoring ALT levels, absolutely not, because he's already been diagnosed with hepatitis C with antibody and RNA positive, okay? So IgM antibody not necessary because we already have positive for IgA, hepatitis A antibody. So this patient need to go for treatment, okay? This need to go for treatment. You don't need to beat the bush, okay? The second question, one more, 2 weeks ago, 40-year-old man went to the urgent care center, request for liver function test and hepatitis C test because of history of past injection drug abuse. The test results were transaminases are normal, AST, ALT, SGO, SGP is normal, total bilirubin is normal, albumin 3.9, which is normal, antibody hepatitis C virus is positive. Now he asks you where should be treated for hepatitis C, is asymptomatic, and the medical history is unremarkable except for the prior injection drug use, physical examination is normal. Which of the following diagnosis should be obtained? C, perfect. You need antibody positive, so you want to make sure it is a true positive or false positive. So SURNA is need to be done, okay? I have last case. 25-year-old female injection drug abuse comes to the ER with 10 days history of progressive malaise, fatigue, anorexia, abdominal discomfort. The patient uses IV and on daily basis for approximately drinks 2 to 3 cans of beer daily. Physical examination, jaundice, tender, enlarged liver. There are no other stigma of liver diseases. Complete blood weight is normal. Alkaline phosphate is normal. SGO, SGP is very high. Bilirubin is high. Albumin is 3.6 grams, which is okay. Surface antigen is negative. Hepatitis C antibody is negative. And antibody, hepatitis C antibody is negative. And IgM antibody B code is negative. So which of the following tests most likely establish diagnosis? IgG antibody hepatitis A? No, because you already have antibody there. IgG antibody hepatitis B core antigen? You don't need, because core antigen is negative there. C, RNA, virus? Yes? Look like, yeah. Antibody surface antigen, yes. Antibody you don't need, okay? So these are the way you had to evaluate the patient when come to your office, okay? So I will stop it here. And since I think, do you have a minute or I'm okay?
Thank you very much for the nice, detailed summary of the hepatitis C. We're really running out of time. If anybody has 1 or 2 questions at the most, the panel can answer them. Just 1 or 2 minutes. He's a good speaker. Yeah.
Just to just update our Indian scenario, we have a lot of Hep C here because the feeding point is from Amalapuram. So a lot of injection practices from local practitioners, medical practitioners, unsafe injection practices. To take the prevalence, we have ranging from 7 to 1.5 is the prevalence around India. And because here the scenario is we see more of genotype 1 and 4. Throughout India, genotype 3 is common, but here is 1 and 4. And probably after the DAS, that's direct diagnosis, we have sofosbuvir plus velpatasvir. Earlier we have sofo plus leadpasvir, and the response is extremely good. And we have government support also, because for the poor patients, we have a established model in Punjab where the government has taken the treatment to the doorstep. They will almost they have screened 30,000 people in Punjab. All they're enrolled and treated, and with a great response. So now most of in Andhra Pradesh government is also partially bears the cost, because the cost comes up to the 54,000 for 3 months treatment. So that's what $900. So the government sponsors around 40,000 rupees. So if the patient can bear 1 month's treatment, I think they are cured of the hepatitis C virus. Yeah.
In fact, the help is available for hepatitis C to eradicate globally. As I mentioned, unfortunately, lack of knowledge, the education for the patient. And, once it is established, I don't think it is a big issue. During my presidency in 2020, I'm going to bring this project, hepatitis eradication, to enter India. Hopefully, you all can help me participate in this program, in the project, okay? And thank you very much, Vishnu, for giving me the opportunity, and enjoy it.
And the government of India, with efforts from all the hepatologists of India, has launched a national hepatitis program. They want to treat hepatitis B and C. Probably in the next 1 year or so, I think the hepatitis B and C treatment will be available free of cost in India. That is the... Thank you very much.
So we're moving very fast now, trying to put the sequence. Please pardon us, we're changing the order of the speakers to see if we can make the last time. Unfortunately, you can't take a break until after the third speaker, so please bear with us. Now I'm delighted to invite our classmate, my close friend, Dr. Pernenkel, to come on the stage and enlighten us about the atrial fibrillation, which is a very common arrhythmia that we see in the practice. It's been there forever, but still we don't have definite answers. He's going to help us identify how to risk stratify these patients, tell us about the various scores to assess the embolic risk, and how to treat the patient, rhythm control versus rate control, etc. He is a practicing cardiologist from Louisiana, and his special interest is in atrial fibrillation. He has been talking about atrial fibrillation for a long time. Please welcome Dr. Ratnakar Pernenkel.
I invite Dr. Venkatrao Garu, cardiologist Kakinada, and also Dr. Leela Nara, electrophysiologist, as the chairpersons.
Good morning. I am very proud to say most of the speakers today are my classmates, and Dr. Ratnakar is also a close friend of mine and is my classmate. The topic is going to address today is atrial fibrillation, whether you call AF or AFib, which is one of the most common tachyarrhythmias seen in our regular practice, mostly in ICU. Once upon a time, when we were students, AF means only rheumatic heart disease, because those days mitral stenosis is very common. Now the rheumatic heart disease has come down, and most of the causes of atrial fibrillation are non-rheumatic, are non-valvular, like we have seen hypertensive heart disease, coronary artery disease, and obstructive sleep apnea, and hypertrophic cardiomyopathy. After the advent of echocardiogram and other investigations, the non-rheumatic and non-valvular AF is seen more frequently. This is one of the most common arrhythmias seen in your regular ICU practice. Regarding the management, most of the times, the treatment can be either rhythm control or rate control. Most of them, they don't need any sophisticated treatment, but some of the cases, some subsets of the patients, they need current latest treatment like electrophysiology, like Dr. Sitting by my side, she is going to talk. So the current treatment, they are available in our country. They are mostly available in Hyderabad. Now there are 5 to 6 centers there, where they are seeing the pulmonary vein isolation and all. And now I request Dr. Ratnakar to address the talk.
Thank you.
Thank you.
And good morning to everybody. It's my privilege to be back at my medical school and give this talk. I'm basically going to base this talk on my practice, which is based on the guidelines that are given by American College of Cardiology and American Heart Association. The most recent guidelines on atrial fibrillation came out in 2014, and there's been an update in 2017. I'm not going to show many numbers or studies, and going to try and keep it simple because it's a pretty big topic. And the way we treat AFib, I see, also depends on the physician and where you are, what drugs you have, and so on. So, why atrial fibrillation? And atrial fibrillation is the most common arrhythmia that cardiologists see now in practice. And it's pretty amazing. I go to the hospital, at least 1/4 or 1/3 of all my work is atrial fibrillation. Whether it be a patient that comes with cardiac illness, or there's somebody in the hospital with, who's coming for surgery and they develop atrial fibrillation. And it's amazing how in the last few years the incidence has skyrocketed. And one of my thoughts is we are maybe monitoring the patients a lot more than we used to in the past. Everybody that comes in is now on telemetry monitoring in the hospital, you know. Anyway, so the point is that it's pretty common, and it's also very age-related. Less than 1% of patients with atrial fibrillation belong to age group below 65. It's commonly seen in people above 65, and up to 8 to 10% of all the patients with AFib are above age 80. It's slightly more common in men than women. And in US, it seems it's a little more common in white people. And the presence and severity of heart disease increase the risk of atrial fibrillation. I'll come to the etiology, and I'll talk a little bit more about that. And as mentioned, we're finding that sleep apnea is a very common cause of AFib, especially so in states because of the high incidence of morbid obesity. Hypertension is one of the most common causes. This slide just shows that AFib is going to be a more common problem as time goes by because the population is aging. And in 1995, in US, there were approximately 2.8 million people with AFib. It's projected by end of 2050, it'll triple, almost 6 million people. So this slide is basically to highlight that this is a disease of the aged. And as populations are living longer, all of us are going to see more of this. I don't think this slide came out very well, but it's basically to point out what are the comorbid conditions or the etiologic factors that cause AFib. And as already mentioned, 60 to 70% of AFib, the two common denominators are hypertension and coronary artery disease. I wanted to say a few things about the incidence of AFib in India. I found a couple of papers, and looking at it, it seems that there is very small information on prospective studies looking at what's the incidence of AFib in India. In the small study that came from, it's called Himalayan Prospective study, it had 137 patients done between 2006 and 2008. And 62% of the patients in this study of 132, they were from rheumatic heart disease. And the second most common cause was hypertension. It was only 10.2%. And the other interesting thing, as compared to populations in US, it seems to affect people much younger. And I believe this is because the most common cause of AFib in India is rheumatic heart disease that occurs in younger people. It's also more, in India, it's a little more common in women than in men. This is the largest study that I could find from India. It's called Indian Heart Rhythm Society Registry. There were 1,000 patients. It was mainly from data collected from 20 cities. And 42% of patients were, or 42% of cases were from AFib. And if you notice from the previous study, these numbers were a lot lower. And they point out The Himalayan study was basically a rural study where rheumatic fever is more common than in cities in India. And that's the reason that this study had a little less incidence of rheumatic heart disease. However, the age group was same, and there was slight predominance of women in India from this study. The point of interest on this slide was, if you remove rheumatic heart disease as a cause of AFib, is AFib more common in Indians than Caucasian populations? And the answer is no. In fact, the AFib incidence is less. And this is a study where it comes from Birmingham, where they recruited Indo-Asians and the general population. And if you can see, the incidence of AFib was a lot less in Indo-Asians as compared to the local population. So I think we can surmise that if you remove rheumatic heart disease as a cause, the AFib is not as common. But my belief is, if as the population lives longer, we are likely to see this more as well in India. Okay, so what are the typical symptoms of AFib? And this predominantly is a factor of the age. I mean, young people seem to present with palpitations or chest pain. In the elderly, they're just present with very non-specific complaints, fatigue, shortness of breath. Dizziness and syncope are also common. On examination, you'll find a faster heart rate, irregular heartbeat, and as we were taught, what's called as a pulse deficit. That is, if you count the heart rate, the pulse is a lot less than if you count at the apex. The big point is the atrial fibrillation can be asymptomatic, and I see this more commonly in older people. And interestingly, I see that AFib causes a lot less symptoms in men than in women. All right, how do we diagnose or confirm AFib? Is it enough to do one ECG and say somebody has AFib? Yes. If you can catch AFib on an EKG, you can make a diagnosis of AFib. However, if you have a normal ECG, there are other ways of catching the AFib, either by Holter monitoring. Now there are devices that can call the patch monitors, which can be worn by the patient for 30 days. Or we also have these implantable loop devices, loop recorders, which are very small. It's an outpatient procedure. They can be left in the patient for 3 years, and that's a good way of identifying as well. And if patient happens to have a pacemaker or a defibrillator, you can get information on those to see if one is having AFib. All right, I want to highlight this slide. It used to be, we used to have various classifications for AFib, but nowadays we have narrowed it down. We call something paroxysmal AFib if the AFib lasts 7 days or less. It terminates by itself, or it's been cardioverted, we call it paroxysmal. If AFib lasts longer than 7 days, it's called persistent. And long-standing persistent is continuous AFib for longer than 12 months. And permanent, you call permanent AFib if somebody has atrial fibrillation longer than 12 months, or the physician and the patient decide not to treat it and leave it alone, then you're going to call it permanent. One important aspect, when we say something is valvular AFib, there are only 3 things that qualify for this diagnosis, and they are patients who have bioprosthetic valves or mechanical valves. And number 2 is if a patient has a mitral valve repair, you call it valvular AFib. And the third thing is rheumatic mitral valve stenosis. So these 3 categories of patients, we call them valvular AFib. Most of my talk today is based on non-valvular AFib, because in my practice, the amount of valvular AFib I see is pretty small, and the 20 years I've been in the present place, I've seen 2 cases of mitral stenosis, and one of them happened to be an engineer from India who successfully had a mitral valve repair for mitral stenosis, which is unusual. That was done at Cleveland Clinic. And I'm now following a patient who has, who presented with an unrelated condition and was diagnosed to have AFib, not AFib, sorry, mitral stenosis. So the laboratory studies done on a newly diagnosed AFib patient is to identify what is the underlying cause. You want to do a TSH as we know that thyrotoxicosis can cause it. You want to know the renal and hepatic function as treatment of AFib involves using anticoagulants. Fecal occult blood testing again to see if, what's the chance of these patients bleeding if we expose them to anticoagulants. And a transthoracic echo to identify structural disease. We talked about hypertensive heart disease, hypertrophic cardiomyopathy, and give you some idea of what's the size of the AFib, size of the left atrium, and to identify cardiomyopathies and so on. The role of transesophageal echocardiogram is basically to rule out any possibility of thrombus in the left atrial appendage prior to cardioversion. And of course, the tests may be warranted to look for PE, acute MI, and acute heart failure. All are potential causes of acute AFib. I think I'll skip this to, this is an important slide in that when atrial fibrillation starts, it tends to be paroxysmal. It's usually triggered by PACs that come from pulmonary vein side, and it becomes, with time, if the patient remains in atrial fibrillation, it causes structural changes in the atrium, what we call as atrial remodeling, atrial enlargement, and that makes the atrial fibrillation persistent. And as the heart structure changes, then most of the reason the patient will have AFib is due to the structural change in the heart, that is enlargement of the left atrium. So in patients, when we are treating them, patients who are presenting newly, they have paroxysmal, and the trigger can be eliminated. So these patients are more amenable to ablation treatments and so on. Now going on to the treatment of atrial fibrillation, the first question is, what are we treating? Okay, we're treating patient symptoms, and so the way I explain to the patient is two things that we do. Number one is to relieve symptoms, and number two is to decrease the chance of having a stroke, which can be the most devastating complication of AFib. Coming back to treating symptoms, we have two ways. We can either control the heart rate and anticoagulate the patient and let them be in atrial fibrillation, as opposed to cardiovert them back to normal rhythm by either chemical means, that is by drugs, or by cardioversion. So there was a lot of controversy in the 90s when we started treating patients, what's the best way to treat. There are 5 or 6 landmark trials which showed that there is no advantage in terms of mortality from either choice. But the big advantage of rhythm control is you relieve patients' symptoms better. So as I initially said, AFib, when it occurs in younger people, it tends to be symptomatic. So the more the rhythm control probably is slightly better for patients who are younger. Dr. Kesani mentioned about the rate-related cardiomyopathy, atrial fibrillation, untreated. I mean, I did say that there are patients who have no symptoms. They can have high heart rates of 120s, 130s for months and years, which can result in weakening of the heart, muscle, and cardiomyopathy. So to prevent that. So these are the 3 issues of treatment. And what options we have. Here I'm just basically highlighting by rhythm control. I mean, if somebody is in AFib, the natural tendency of a physician is to put the patient back in normal rhythm. Sinus rhythm is a normal rhythm, and that's a good thing. If you do that, I mean, that's what traditionally physicians have preferred. It does not improve mortality. It does not decrease the chance of stroke. All it improves is quality of life. So this option might be very good for patients who are symptomatic and younger, which I think I already mentioned that. And rate control is a lot easier to accomplish. And we don't expose patients to the antiarrhythmic drugs, which have their own problems. And it's well known that patients who are rate controlled have less hospitalizations. So when controlling the rate, what are the strategies? It's basically said that at rest, the goal is to get the heart rate to between 60 and 80, and patient exercising, you want the heart rate between 90 and 115. For this, we can use either AV nodal conduction blocking drugs, which is first-line drugs are beta blockers and calcium channel blockers. I'll mention to them in the next slide a little bit more about these. To slow the conduction, you can use drugs like digitalis, which nowadays, basically, we use it in acute AFib. I find DIG's role is basically where patients are hypotensive and you're running out of option with drugs to lower the heart rate, and DIG is the drug. It does not lower the blood pressure and good at lowering the heart rate. And of course, we have amiodarone, which is a drug that's very good at both lowering heart rate and trying to bring the patient back in sinus rhythm. But that's a drug that comes with a lot of toxicity, and it's definitely not a first-line drug. For rhythm control, we have various options. We can cardiovert a patient electrically. And this is usually used when patients are unstable hemodynamically, low blood pressure, shock, or they're having unstable angina, and you would want to immediately cardiovert a patient. Otherwise, the choice are medications, antiarrhythmic drugs. If you want to convert a patient to normal rhythm, either by electrical or by chemical means, and if the AFib has gone on for more than 48 hours, one has to anticoagulate the patient. And I'll give some guidelines on how long and with what. Coming to antiarrhythmic drugs, the class 1C drugs, flecainide and propafenone, are basically used if a person has no structural heart disease. Class 1 drugs which were used in the past, quinidine, disopyramide, and procainamide, are no longer used. I've occasionally, on a rare occasion, used disopyramide in a patient with AFib secondary to WPW syndrome with real high heart rates. Intravenously, it works well, and that's one disease for that particular drug. Class 3 drugs can be used as sotalol, dofetilide, and one word of caution with these drugs: they can prolong the QT and can cause torsade du pointe. Amiodarone is a very good option for patients who fail other drugs and patients who have more structural heart disease. Dronedarone, which is an improvement of, they made this drug cleaning up amiodarone, removing an iodine molecule from it. So it's a slightly cleaner drug, but not as efficient as amiodarone in keeping somebody in sinus rhythm. One word of caution: dronedarone is contraindicated in patients with decompensated congestive heart failure. Here is a list of drugs that we use for rhythm or rate control. Rate control drugs are used mostly in an acute setting in the hospital. I see in most places that I work, IV diltiazem used as drug of choice only because it's easy to administer. Patients who have COPD and so on, a better drug of choice would be beta blockers. For acute patients, esmolol is available, but it comes with a kind of a complicated regimen. That's why it's not very commonly used. But if you have somebody who has bad lung disease, that's a good drug to use. Other drugs we use for rate control acutely, verapamil comes in an IV form. On chronic basis, you can use beta blockers or calcium channel blockers. And I've already talked briefly about the antiarrhythmic agents that are available. Okay, so you see somebody with the first episode of AFib, you are planning to bring them back to normal sinus rhythm. Should we use a drug to keep them in normal rhythm? I would say my practice is if it is due to an acute condition such as thyroid disease, pulmonary embolism, once you treat the underlying condition, AFib subsides. For the first 3 months you may anticoagulate and treat them, but they don't really need long-term treatment unless they have a lot of structural heart disease. So in these patients, clearly we don't need to use any drugs to prevent further episodes of AFib. But patients who have underlying heart disease, second, third episodes of symptomatic atrial fibrillation, I think it's good to use a drug to prevent recurrences. What are the good drugs to use for preventing recurrences? Unfortunately, all the drugs that we have very low efficacy rates. The commonly used sotalol and propafenone at the end of 1 year. If you look at these patients, maybe about 30% of patients are in sinus rhythm. The best drug to keep somebody in normal rhythm is MAO. It probably has maybe 45 or 50% chance of keeping somebody in sinus rhythm long term. So, again, to summarize that, if somebody who comes in with first episode of AFib, there is a treatable underlying cause. I don't usually use a drug to prevent, but if somebody is coming with a second or third episode, I usually use one of those antiarrhythmic agents to keep them in sinus as long as possible. Some guidelines here for cardioversion. If you elect to cardiovert somebody, again, as I said, the need for cardioversion is for patients who are symptomatic, and you have tried some drugs, the patient has been in the hospital for 2 or 3 days. You don't want to keep them in too long. That's another reason maybe you'll cardiovert somebody electrically. So for electrical cardioversion, if somebody has been in AFib for longer than 48 hours, you have to anticoagulate them for 3 to 4 weeks before you cardiovert them. And after cardioversion, you have to keep them at least for 4 weeks on anticoagulants. I'll say something about choice of anticoagulants in a little bit here. And for now, if you want to cardiovert somebody quickly, you don't want to wait for 3 to 4 weeks, one option is to what we call as a TE guided cardioversion, where you can do a TE, rule out any thrombus in the atrial appendage. If the patient does not have any atrial appendage thrombus, you can shock them, bring them back into normal rhythm, and cardiovert them and keep them on anticoagulation for 4 weeks. So this will shorten the period where you have to anticoagulate them for 4 weeks prior to cardioversion. So that's the advantage of doing a TE guided cardioversion. So as I said, the objective of treating atrial fibrillation, number 1 is treating the symptoms, number 2 is to reduce the chance of having stroke, and to reduce the chance of stroke, you're going to anticoagulate people, and we're now using this scoring method that's called CHAD-VAS2 score. As I have shown here, there is each of these risk factors, CHF, hypertension, age above 75, diabetes, all carry 1 point. And if somebody has had a TIA or a previous stroke, that carries 2 points. Vascular disease as defined as previous MI, or presence of peripheral arterial disease in the lower extremities, or aortic plaque. Of course, aortic plaque we identify on TEE, and if there is more than 4 millimeter plaque, it's considered as significant. So this scoring system has good basis. It's been shown that if the CHAD-VAS score is 0, your chance of having stroke is 0. But as it goes up to 9, a chance of having a stroke in 1 year, somebody who has score of 9 is 15%. That is that 1 in 6 chance of having a stroke. This keeps coming up. Let's see, okay.
Something messed up again.
All right.
Can you just finish it?
Yeah. Okay, good. So when you see a patient, you see what their CHAD-VAS score is and give them anticoagulation. Basically, anybody who has CHAD-VAS score of more than 2 should be anticoagulated. And again, I want to say one more time, most of my talk is for non-valvular AFib. I mean, somebody has valvular AFib, we are totally in a different ballpark. Of course, if you expose somebody to anticoagulation, there is a chance of bleeding, and most of the studies show the chance of major hemorrhage is about 1.2% per year, which is a lot more acceptable than the high stroke rates you see in these patients. And usually we define major hemorrhage as an episode of GI bleed that requires 2 units of blood transfusion. Okay, which anticoagulant? Until about 10 years ago, all we had was Coumadin, that is vitamin K dependent factor anticoagulant warfarin. And now we have 4 new anticoagulants in the market. The dabigatran, which is a direct thrombin inhibitor, and there are 3 others, rivaroxaban, apixaban, and endoxaban, all 3 of which are factor Xa inhibitors. What are the advantages for new oral anticoagulants? Other than what you see here on the slide, the biggest attraction for patients is if you have somebody on warfarin, you have to have monthly blood tests, and there is some restriction in diet. You cannot have vitamin K, so you tell them not to eat greens. Whereas when you use these new anticoagulants, you don't have any such restrictions. The effect is predictable, the doses are fixed, and there is no restriction on diet, so they can be on, they can eat all the greens they want. The main problem with the new anticoagulants is we don't have any reversing agents at this time, and they're extremely expensive. I'm not quite sure. I'm going to ask Dr. Pulavati to comment on the newer anticoagulants are called NOACs, if they're available, and what is the cost factor in India here, because I understood from him it's very difficult to do INR tests here, you know. Okay, when should we consider non-drug therapies? I briefly talked about ablation. There are different types of ablations. Patients who are younger, who have less structural heart disease and symptomatic. We have something called pulmonary vein isolation, which is basically an ablative treatment. And we use AV nodal ablation for patients where you cannot control their heart rate, they're still symptomatic. But AV nodal ablation requires prior pacing of the patient. You need to implant a pacemaker so that they can have a decent heart rate. Other options to decrease the chance of thrombus, one can occlude the left atrial appendage, and for occluding the left atrial appendage, there are some new devices. I'll show pictures of a couple of those devices. Here is a trial which compared the effect of ablation versus medical management. When ablation came new 10, 15 years ago, it was thought to be that it's a great treatment, patients have a cure, but when patients have ablation, it really only effectively stops AFib for, at least in my experience, between 5 and 10 years, and it recurs. So this trial looked at what are the advantages. There were some problems with this trial in that they had hard time recruiting patients, and they had to change the primary endpoint from mortality to other things. So this study found there was no major difference in mortality, rehospitalization, and so on between the two groups. And basically the authors recommended that consider ablation in younger patients where medical therapy has failed and they are symptomatic. And also for younger patients who have structural heart disease, because in younger patients, when you bring them back to normal rhythm, sometimes or most of the time their ejection fraction improves and there is a positive remodeling of the heart. Here is some of the devices that are used to occlude the left atrial appendage. And if a patient is having bypass surgery, they can have the lower part there, they can have the appendage removed. So clinical bottom line, I'm going to read this slide. The gist of my talk here, the goal of treating atrial fibrillation is to reduce symptom frequency and severity and prevent stroke, prevent tachycardia-related cardiomyopathy. And we use the CHAD-VAS score to select patients for anticoagulation. If you choose to control the rate, the targets are to keep the heart rate between 60 and 110. And attempts at rhythm control if patients do not respond to rate control or do not tolerate atrial fibrillation. And AFib ablation and AFib nodal ablation therapy may be appropriate when patients remain highly symptomatic. Closure of left atrial appendage is an alternative to giving thromboembolic protection. I think that's all I had, and if you have any questions, I'll be happy to answer, and I'll ask Dr. Pulavati to briefly say about availability of NOACs, the newer anticoagulants.
They are available now.
Thank you.
This INR, no, this is a test available here, but no, the report varies from lab to lab, and in the same lab with the same blood sample, we get different reports. So not reliable most of the times. That's why now we are preferring the vitamin K and non-vitamin K antagonists like Tavaraxpan and all.
Are they available?
Yeah, available. Okay. Yeah. Not very expensive, but they're available only for a few patients we are giving now. Slowly, I think we will increase the number.
Sir, can I ask you quickly to comment on your experience that way?
Yes, hi, good morning. I'm from Guntur Medical College, but I always love coming to Rangaraya reunions with my husband. I really love it, actually. We all know that atrial fibrillation begets atrial fibrillation, and the longer they stay in atrial fibrillation, the harder it is to get them out of atrial fibrillation. So you want to cardiovert them, you want to treat them with antiarrhythmic drugs, and mostly in paroxysmal atrial fibrillation, when they have recurrent episodes, despite treating them with all these antiarrhythmic drugs, which have a lot of toxic side effects, the next step is to ablate them. And the guidelines are basically patients with symptoms and not responding to antiarrhythmic drugs. These are the candidates for AFib ablation. And asymptomatic atrial fibrillation patients, we don't want to ablate, period, okay? The outcomes, the success rates are 70 to 80, at the most 90%, and the recurrence rates after 3 years is pretty high. This is a consensus report. And I do the pulmonary vein isolation right now. It's mostly radiofrequency ablation. I don't do cryoballoons. And the success rates are pretty good. 2 years, I don't see any. But some of these people remain on antiarrhythmic drugs for a short time. And I leave them on anticoagulation for indefinite period, because there's a good chance these people will go back into atrial fibrillation and they can actually stroke out on you. And we don't want to leave them alone, okay? And you follow them until, I follow them until I'm there, until I retire actually. These people, they come to me. But anyhow, right now for paroxysmal atrial fibrillation, we are doing only pulmonary vein isolation. We're just isolating the veins. We go into the left atrium via transeptal approach and we isolate all the veins because we know the PACs that start, they come from the pulmonary veins, actually irritate the atrium and put the atrium into the atrial fibrillation. So that's the approach right now. Initially they went with focal, but now we are doing pulmonary vein isolation. But now what about persistent atrial fibrillation patients? What do you do with these people? And chronic atrial fibrillation patients who are very symptomatic and you don't want to treat them with antiarrhythmics anymore because they're chronic. So right now we're trying to do some surgical hybrid procedures, convergence procedures where the surgeons will go and ablate the posterior wall of the left atrium, and electrophysiologists, we clean up the anterior part of the veins and the ridge of Marshall, and that actually have very good outcomes in these people. So that's where we are moving, trying to even treat these persistent and chronic AFib patients too. I don't have much experience with cryo balloon. I haven't used it because it's pretty expensive, and I'm using RF ablation right now. Okay, and we do AV node ablations, modifications like you mentioned for rate control. Okay, so that's about for AFib ablation. Yes. Sure, no problem.
Sure. 1 second. Thank you very much, Dr. Pulavarthi and Dr. Nara, for contributing to this part of the discussion. And I congratulate Dr. Ratnakar for doing an excellent summary of the atrial fibrillation. Because of the time problem, we can only take one question.
Thank you, Mr. Chairman. I enjoyed the good presentation you gave us. Thank you, Ratna. My comments and questions.
Sure.
Atrial fibrillation, clinically picked up by the pulse deficit as well as irregular pulse. I tend to see in my practice in West Indies, Jamaica, the commonest cause in the young people is rheumatic heart disease, as you rightly mentioned too, in your experience. In the middle-aged people, it tends to be thyroid disease. That's the commonest cause of atrial fib. One of your slides showed, in looking for thyroid function tests, TSH. Undergrad, postgrad teaching says a normal TSH rules out thyroid disease. Is that true? The answer is it's true.
Yeah.
However, the selection of TSH that you make should be HS-TSH, highly sensitive TSH. In American College of Physicians conference earlier on this year in New Orleans, one of the professors in endocrinology made the point that in elderly people, it may be subtle or subclinical thyroid disease, so they may not have fluid presentations. The question is, do you anticoagulate them? The answer seems to be, no, it's not urgent, don't do it. Watch them, monitor them, and they might be normal. In a few months or a year or two, they may just revert to normal without any treatment. Regarding the anticoagulants, Novox, rivaroxaban, edoxaban, apixaban, dabigatran, the New England Journal of Medicine published 10 years ago the research and analysis of dabigatran conducted in South Africa compared them with vitamin K anticoagulants. The machines that were tested were defective, and that was challenged, and they accepted, and they withdrew the article from the New Journal.
Thank you very much, Dr. Siramalas. Just because we encourage everybody to talk to the concerned speaker privately, so that we can catch up with the time.
Thank you, sir.
Thank you very much for your contribution. Thank you very much, Ratnakar. So, all the speakers will be available here. Please feel free to go to them and ask your questions. They'll be more than happy to answer. Now it's time to take a break. I should have done the house calls before I started the conference. There are 2 washrooms on the right side, women and men's, and they promise they will keep it very clean. There is a person standing there and cleaning, so feel free to go there. And there is food on this side, snacks, please go there. You're all getting for 10 minutes of a break for your patience and interest. We'll start in 10 minutes. The next topic will be hypertension by Dr. Prasad Kilaru.